All right, I think we can get started now. Um, we're 3 minutes in, so we'll just let other people trickle in. But welcome to another session of Advancing Health Equity Together seminar series. For anyone who's joining us for for the first time, this is really an opportunity to learn more about the basics of community engaged research, learn from like community and academic researchers on their practices and strategies, practicing community engagement and research, and also really an opportunity for you all to consider how you might be able to implement and integrate some of those approaches into your own research. Our today's focus is going to be on the tools for empowering community, tools for community empowerment. We're going to start with just brief methodological introduction to kind of just provide a generic context and background for for like the presentations, and then that will be followed by a panel presentation. I'll now pass it to Devin to kick us off.
Thank you so much, Timnit. And thanks everyone for joining us on this Wednesday afternoon. We wanted to just begin by briefly grounding folks in Paulo Freire's ideas about critical pedagogy and about critical dialogue. For those of you who are familiar, this will just be a real quick refresher. For those of you who are newer to this, there's so much more out there in the world to discover about Freire and this topic. And we encourage you to really dig deeper than we'll be able to even get in the few minutes that we're covering this. So Paulo Freire was a Brazilian educator and philosopher who was actually exiled from Brazil in the 1960s before he wrote his seminal text, Pedagogy of the Oppressed, which we highly recommend folks read. He really saw education as a tool for dismantling oppression. He was hypercritical of the models of education that he saw at the time, that pitched really the teacher as the expert who would deposit their knowledge into passive students, really what came to be known as the banking model or deposit model of education. Students were not at that time given a lot of latitude to express themselves. They were not really encouraged to think critically or challenge the information that they received. Again, they were just sort of like passive recipients of the information that the teachers passed down. And so Freire thought, there's something wrong with this. He saw that education, based on who was in power at the time and who was hoarding that power in the classroom, was really being used in ways that kept marginalized and oppressed people down. And he saw that this was dangerous to the student and also to the teacher, and instead really advocated that education should be a place that elevated everybody's quote unquote critical consciousness. So he really saw the classroom and education as a place where students could be given large questions or problems to tackle that were based on the context of their everyday lives, that were directly relevant to them. And given that they were experts on their own lives, Freire contended that if they had the space to tackle these problems and bring their lived experience to the room, they would engage in a process called critical dialogue that would help yield their emancipation because they would come to better know and understand the ways in which the systems were keeping them down. It was then, he said, that students could actually take action to make changes and that those actions would be more responsive to the change that needed to happen. So if we go to the next slide, when we think about this in light of community-based participatory research work, it's really hard not to be struck by the parallels. We talk in public health a lot about social determinants of health and how they contribute to the inequities that we see day in and day out. And really, what are those social determinants of health if not the results of those oppressive systemic forces that keep people down that Freire was really calling upon? So those of us who work in community engaged research recognize that people are the experts of their own lives. That's why we want to do the work with them. They can help move it forward in more meaningful ways, right? And so this is This is very akin to how Freire saw students. Our communities know the challenges that they face. They also know the assets that they hold. Engaging in community engaged research means that they get to bring that wisdom to the table to drive the decisions. And when they do, when they have the space, again, to really talk about what matters to them, we can have research that's meaningful and that leads to action. And that action is action that they are directing and actively a part of. So there have been a few CBPR researchers who have really talked, there's been a lot of CBPR researchers who have actively talked about their experiences and how they align to Freire's work, including Wallerstein, who we cited on this slide here, who's obviously a thought leader behind CBPR. And you can see the article that we referenced there, and there's a QR code for those of you who want to dig in a little bit more. Rodriguez and Nunez are other public health scholars who have been exploring this work. And this is a conversation that's been, it's been going on for decades and continues to get light on it in really exciting ways. And so we wanted to, before we get into our really exciting panel, leave you with what they articulate as the core values behind using such an approach in CBPR. First, we should always be concerned with the impact of the research we do, right? We should want the research to be transformative in some way, shape, or form. And because we want that to be a positive change that leads to equitable and healthy communities, we need to make sure that we're listening to the people and communities that we're trying to serve. In doing that, we're actually able to go through a process that Freire calls co-creating knowledge. It's through this process that our collective community consciousness gets raised, because we are all community researchers and academic researchers engaging in processes of critical questioning and collaboration that can lead to action. So at the end of the day, there should be a research impact on health, but there will also be an impact on the people we engage with in the process and ourselves as the researcher, because as we go through this process, kind of no one should be unchanged if it's done successfully. And with that, I will pass it back to Timnit to introduce our esteemed panel.
Thank you so much, Devin. That was a very helpful background. So today we're very excited to have a great panel. Our first panelist is Dr. Victoria Ngo, who's an associate professor at CUNY SPH, director of the Center for Innovation in Mental Health, and mental health director of the Center for Immigrant, Refugee, and Global Health. Her research focuses on mental health interventions and implementation strategies to improve access and quality of care for ethnic minorities and underserved populations. She specializes in task sharing and community participatory methods to integrate mental health services into primary care, maternal health, HIV, cancer care, schools, and many other settings. She has led several NIH studies, and Dr. Ngo also leads the Harlem Strong Mental Health and Economic Empowerment Collaborative to integrate mental health services in Harlem, and serves as a senior technical advisor for USAID and collaborates with New York City government to support mental health integration in diverse communities. Our second panelist, Faven Aya, currently serves as the Director for Community Engagement and Health Equity Research at the Arthur Ashe Institute for Urban Health, where she manages the Institute's community engagement and research initiatives on mental health, cardiovascular disease, HIV, AIDS, and social determinants of health, among many other things. She also leads Communities Together for Health Equity, which is a citywide network of over 70 community-based organizations working together to address the social determinants of health by bridging gaps between the community and the healthcare system. Through strategic partnerships, she collaborates with a wide range of stakeholders, sectors, and institutions to ensure that equitable and strategic solutions that leverage community experience and expertise are integrated into research, healthcare planning, and inform policies and practice. She received her Master's of Public Health in Epidemiology at the Icahn School of Medicine at Mount Sinai, and is currently pursuing her Doctor of Public Health at the SUNY Downstate Health Sciences University. Thank you so much both for joining us today. We're so delighted for this session. We're going to have a Q&A session at the end, so we'll preserve all questions for that. But if you want to drop any questions in the meantime in the chat, please go ahead and do that. But without further ado, I'll pass it to Dr. Ngo to start us with the presentations.
Great, thank you, Timnit. Let me see if I can share my screen. Okay, oops, let's see. is everyone able to see this?
Good to go.
Great, thank you. Thank you so much for having me. I'm really delighted to be here and to be, part of a panel where we get to talk about community engagement, because I think it's so important to the work that we do, especially for those of us who are focused on health equity related issues. So thanks again for the introduction. I'm going to talk more about Harlem Strong and our coalition and our process and approach for community engagement and partnership. This is a study that's funded by 2 grants. One is the NIH U01 System Transformation Initiative, which is about, system transformation for health equity related issues. And ours is particularly focused on mental health and social issues related to that. We're also funded by the RWJ Systems Transformation Initiative. And so, from both of those funding organizations, we get a lot of support to think about how we can transform systems and how we think about health equity and hear about it across a variety of different public health issues. So it's really been very useful and collaborative in that way. I also want to thank our partnerships. We have our key partners, Harlem Congregation for Community Improvement, which is a housing community improvement organization, and they've been just incredible in terms of transforming Harlem, for around housing issues, but also integrating social and behavioral health services into their programs. Health First is a managed care company that's been very critical in leading some of this work and engaging the primary care partnerships. And then we have the Harlem Health Initiative, which is also based at our school. And we focus on bringing together academics and community-based organizations around a variety of different issues through the Harlem Health Initiative. So with that, I will move it on to the next slide, which is, oops. I'm having a hard time making it move. Okay. So I want to acknowledge and thank my co-leaders. We have Dr. Malcolm Punter, who is the CEO of HCCI, Deborah Levine, who is the director for the Harlem Health Initiative, and Dr. Susan Bean from Health First. And together we actually started planning this before the funding started. So, when we talk about community engagement and partnership, much of the work that is needed has to happen before you get the funding in many ways, right? Because otherwise the planning happens after you get the funding, but then you have to create the plans, in order to get the funding. And so this all grew out of early conversations we had right after COVID-19. At the start of COVID-19, our school was involved in a weekly assessment of what was happening in the community, New York City and the state in terms of impacts of COVID. And I was particularly interested in mental health. And through that process, we learned, how high the rates were in New York City, and got together with Deborah Levine and Dr. Punter to hear specifically about what was going on in Harlem. And it was very clear the needs were great. We got connected to Dr. Bean at that stage as well and started thinking about what can we do to support our community to respond to COVID-19, but also to respond to this rising, crisis that we're encountering across all systems, because behavioral health doesn't just exist in the mental health system, it exists everywhere. And so we wanted to first understand what was happening, and through our partnership, we just started talking to different organizations to hear about what they're seeing, what they're wanting to have happen. And it was very clear that we needed a collaborative effort across multiple organizations. And we first engaged in a needs assessment just to understand, and so I'll talk a little bit about that planning prior to the grant actually getting funded. But so I think one of the things to keep in mind here is, as you're doing community engaged work, it has to start, it's best when it's sort of organic, when it rises out of an issue that the community's already trying to deal with and to respond to, because then the collaboration and the partnership is a very natural partnership. And that makes it much easier, because this work is very hard, and it's harder when you have to forge and really create new structures and new processes. But for Harlem Strong, our goals were really to address the rising mental health and socioeconomic inequities in Harlem. One of our main aims was to develop a coalition, a multi-sectoral coalition to support integration of mental health services and resources. Second is to build capacity around mental health. And so we provided a variety of different trainings that we offer to navigators and other support personnel within the network. We want to increase care access. We've heard loud and clear throughout all of our needs assessments how difficult it was to get access to mental health services. And so to do that, we realized we needed to integrate it to more community accessible locations, like, within housing, primary care, and community-based organizations, people who are already on the front line, organizations that are already on the front line supporting community members to respond to a variety of different issues. And then the fourth thing is we needed local data. We wanted to make sure we evaluated the process so we could learn about it. And we actually are implementing a step wedge study that is a hybrid implementation and effectiveness study. And we're looking at the effectiveness of different models of care, different, approaches for implementation, in addition to, testing the effectiveness of the actual intervention, which in this case is like a collaborative care model where we're implementing like a step care process where we're doing screening, psychoeducation, assessment, and very brief intervention that is provided by navigators. And so one thing, to keep in mind here is that everything that we do in Harlem Strong, we feed back into the community. So when we have a community, coalition meeting, we write up a report, we share the results, the recommendations. When we do trainings, we ask for feedback, and we incorporate that feedback back into the next session. We have weekly meetings or bi-weekly meetings with the organizations that are part of our initiative. So we're constantly, feeding back things that we learn. And I think that's one of the important things about CBPR is that there's a two-way communication. It's not just we, get feedback from the community and then we go and do our research and then we return with the results 4 years later. It's quite iterative in the sense that there's always this back and forth. And so the evaluation is not just an evaluation at the end. It's sort of like they're hearing about the research and learning about what we're finding week to week, month to month, so that it can support decision making, in the program, rather than waiting to the end. So research here becomes very much practical. It's very practical, pragmatic, and about having data to respond to decisions that you need to make in the field in your programming. Our model is a multi-sectoral collaborative care model where we are basically connecting navigators who are placed in housing and primary care, which are our two gateway sites where we're actually studying. And then we're connecting them to behavioral health, faith-based organizations, and CBOs. All of the organizations that are part of our network can get the training, can implement the model. It's just that we don't have the resources to study everybody. And so we're only studying the two gateway sites that we're focused on, which is housing and primary care. Our program includes 6 components. First is community outreach. In order for mental health task sharing and integration to happen in these different, settings, the community needs to be aware of it, and there needs to be connection into the community. So our first step of the process is tabling, being out in the field, walking the streets, promoting mental health, and working with all the organizations that are already doing this kind of work to table, to do outreach together. Then we provide screening for mental health distress using the PHQ-9. We also provide a psychosocial assessment and a risk assessment to determine the step of care that the person may need, provide client education about mental health, and then offer stress management, wellness skills, counseling, and then referrals and connections to care. So that's the program side of it. Our process for community engagement started in our first, actually started before the project started, but during the first year of our grant, we basically did a landscape kind of analysis to see who are the players in Harlem? What are the different organizations that exist? What do they provide to learn about them? And we invited a variety of different organizations into our coalition. We have service organizations like the CBOs that provide social services or other types of services, faith-based organizations, houses of worship, behavioral health providers, primary care providers, housing providers. We also invited city agencies, policy leaders, Health First, which is a health insurance company, community leaders, consumers, residents, and academic partners to come to the table. And so that is the network itself, the coalition. Within that coalition, there's the service organization, which is what you see here. And so there's a more focused attention on their specific needs, but we also need like the larger ecosystem to support them. And so there's almost like the 2 layers of a coalition. Our community engaged planning involved multiple steps. Before the project, we actually initiated some of the needs assessment that continued on after the project started. We also convened a community advisory board made up of the types of folks that I listed earlier. And that group, reviewed our plans, kind of our goals. We also asked them about what they wanted to see and who else needed to be brought to the table. We did a literature review. We also did that landscape analysis, kind of looking at the different types of organizations, what they provided, so we can identify the gaps. We had a series of meetings that were focused on community stakeholder design sessions. And so basically there are different types of community groupings, depending on what it is that we wanted feedback on. So, when we did sessions focused on trainings, we wanted the types of people that would participate in training so that we can get feedback on that. We had 9 sessions. We did one that was across the board, across the coalition, and there we identified needs and opportunities and where the gaps are. Then we had one that was focused on the intervention itself, got feedback on the intervention, then about the implementation process, and then training, and then technology. And so there's a variety of different topics, and they are made up of different groups. That feedback is integrated with our needs assessment survey and our interviews. And then that's brought back to the coalition so that they could learn about what we found. We also work with the coalition to co-present together as well. And so we have leads in the coalition that, for example, presenting back to community boards 9, 10, and 11 in Harlem. We present. Sometimes organizations within our network want us to present to the rest of their organization. And so we'll go out and do that. So there's a variety of different ways in which we share back the information. But here's just a sample of some of the feedback that we got in our initial rounds of the Community Stakeholder Planning Council. Very clearly, racism is a very strong theme. We wanted to make sure that we address institutionalized racism through our efforts, as well as internalized racism and discrimination, and how that may get presented when people are receiving services or trying to access services. And so we integrate that conversation into our trainings and into our coaching. Another thing that came up from this that we did pay attention to, but we didn't realize how strong of a focus it became in our project, which is like the theme around healing the healers. Provider burnout was such a major issue for us. We had such a high level of dropout. All the organizations were saying how hard it was for them to maintain their staffing. And so, normally at these sorts of trainings, I do the self-care and provider burnout stuff at the end after we do the training. But, for this project, we actually put it up front and use that as a way of engaging organizations into training, because that's what they are interested in. And it's really important that they feel taken care of in order for them to participate in this kind of work. And so, one of the things that we got out of this process is really switching our focus to the providers and the organizations and supporting them first before we think about, supporting the consumers in the community. Stigma, of course, is a huge issue in this community and many other communities. And so, we wanted to really leverage the partners that already had trust in the community, that, already had the ears of community members like houses of worships and other community-based organizations and leaders to help us think about how to engage in these conversations and to integrate these conversations into other conversations that are less stigmatizing, like, health conversations that they might have with their providers, or reframing the conversation of mental health around wellness. And supporting just like integration of wellness for everybody, rather than just on those who are identified to have depression or anxiety or any other severe mental illness. So those are some of the things that came out of these meetings. And that was integrated into training and our coaching. The other thing that we did was we, went through the different needs and opportunities that people identified and then divided them into domains. And then we also had like breakout sessions where we could focus on specific domains so that they can identify challenges and needs and then also identify the opportunities. With those opportunities, we then created like an action plan. And so, they came up with action ideas that they wanted. We listed out all of them and then kind of prioritize. And then the group identified specific areas of action that they wanted to see and what they wanted to see in those action plans, and so things like, around the coalition and coordination, they wanted the decision makers to hear directly from the service providers. They wanted to, begin the process of identifying system champions within the organizations that can help move this agenda forward. Ideas like data sharing across organization, came up as well. We were still kind of working through those pieces. Certainly increasing access to services was very central to, what folks wanted to focus on. And so implementing a step care process so that people can participate in the parts that make sense for them. Not all organizations and not all types of providers want to implement all aspects of the program. So we created a very flexible process. Issues around hiring and, things like that were things that we talked about a lot in our, in these action plans and how to take steps towards that. And so one of the things that came out of that was like bringing in care navigators that we had through internship programs and providing, basically positioning them in these organizations to help support the organizations to engage in this work. We also kind of talked with them about like where and how to implement some of the action ideas, some of the activities that they wanted. And so we have them listed as well. And so all of this is shared back with the community members and the coalition members so that they can see how we're taking their ideas and implementing it. Just to wrap up, I think, some lessons learned here is just, it's so important to be responsive to the community. And for us, it was about how to find the wins for all parties involved, and so there's different wins for leaders, the leadership versus like the actual providers and the community members, right? And so kind of keeping all of those in mind. So for the organizations, all organizations are overwhelmed right now. And so engaging in more research, engaging in services, especially if it requires like changes to their workflows or new staff or additional training is very difficult. So we tried to find ways that we can support the organization and the leadership. So if it's data that they need, we share that with them. If it's analysis of data, we do that. One of the things that's coming out of this is we're developing an EHR system for the community-based organizations that don't have that, and that for them would have cost thousands of dollars, but we're doing that and making that free and available. We are helping to connect them to grants and, doing little write-ups of what we find so that they can use that to incorporate into their own, process so that they can use the work that we do, to get more funding for themselves, connecting them to resources around internships and things like that. For the navigators, we wanted to create professional development opportunities to make it so that it's a win for them. So it's not just participating in training, but figuring out, what kind of academic credits do they want or, continue education or whatever it is, and then seeing how we can incorporate that into our training so that it's useful for them. We also do a lot of things around prizes and recognition because we want to make sure that people feel valued. That's really important in the line of work that we do. And there's a lot of flexibility built into the trainings. I think that was very clear to us that we can't have a rigid model that's like, too structured because there's just a lot of competing demands. So we created a hybrid flexible model of training. We adjusted the training curriculum, and schedule quite often. We provided on-site coaching and support, and, finding other ways to work together with the community navigators. And so all of this is to say is that a lot of this changed because of the feedback we got. We really needed to make things much more flexible than they were originally conceptualized in the grant, which also means that there's a lot more resources needed to do this work. But, at the end of the day, I think, the lessons learned for us is the community engagement partnership is so essential to any work related to health equity. You really can't do this without these partnerships. It's really hard to engage organizations and providers unless, you know, it makes sense to them, right? It has to be responsive to their needs. We found that we needed to do broad stroke stuff, you know, kind of planning that's very broad so that it can include everybody, but we also have to have very detailed planning so that it's relevant for every organization that's working with us. And so it's all, you know, you're constantly fluctuating between like addressing the needs of everybody and addressing the needs of specific groups, and then adjusting accordingly, and then understanding the incentives and the barriers within each organization that we work with. And so some of that is about kind of understanding your membership, you know, your organizations, and what they need, what they want, what are their goals, or how aligned are they with your goals. And then for us, you know, I think one thing that for implementation, any kind of service implementation, really understanding the workflows and, you know, how things actually work within an organization was really important to make things, you know, to make it workable. That's often where things get stopped, is it doesn't fit with the organization's workflow. And so really getting into the weeds on that was very important. And for us, that means that, you know, if you're doing community engaged work, you really need to be integrating in more resources on the front end to really, you know, have time and energy and staffing to really understand, you know, organizations that you're working with and the partners that you're working with, so that it can be productive. And all of that requires a lot of flexibility and adaptability. And sometimes I think, you know, our study is an randomized control study, and I kind of wish that it wasn't, because it does limit us in some ways, and it provides a very high, it requires a very high level of rigor that, you know, sometimes they be in conflict with the flexibility and adaptability we need to be able to respond to community needs. And so I'm always kind of weighing that out. And I think, you know, as you all engage in this kind of work, that's something to think about. And with that, I just want to thank everybody and see if anybody has any questions.
Thank you so much, Dr. No. That was a very insightful presentation. I think we'll just do questions at the end, and for the interest of time, just pass on to our next presentation. Faven, go ahead.
Bye.
Thanks, Timmy. I am going to pull up my slides. Okay, are you guys able to see my slides? Okay, perfect. So again, my name is Faven Araya. I'm representing the Arthur Ashe Institute for Urban Health, but I'm going to be talking about our work leading communities together for health equity, which is a network of over 70 community-based organizations throughout New York City. And they are working together to address the social determinants of health. And why CTHE is relevant is because, I mean, the state has done this multiple times, but back in 2014, the state reinvested about $8 billion into transforming the healthcare system with a very specific goal of wanting to reduce emergency admission and readmission rates by 25%. And so there was an initiative called DSRIP, which is a really long acronym for Delivery System Incentive Payment Program, which really just translates to healthcare transformation. And what we recognized about specifically emergency department use was that it was predominantly folks who were low income, who were uninsured, underinsured, and predominantly communities of color. And these populations were mostly served by community-based organizations to address their social needs. And it was a lot of the social drivers that were getting them in the emergency room. So a lot of folks were using it for urgent care. They were dealing with chronic diseases that have been unintended or not tended to. People were using it as a place for shelter, for food, for protection. And so when the state rolled out DSRIP, we recognized that there wasn't a plan and a strategy for community engagement, despite there being a really important need to address social factors. And so Communities Together for Health Equity came together as a result of a group of small grassroots CBOs who advocated for the need for community engagement. And as a result of that process, the state developed its first CBO planning grant, which was awarded to the Institute, and then it was replicated in other parts of upstate and Hudson Valley and Long Island. So that's a really, that's a primary example of how CBOs are playing an active role in informing policies and practices. And now fast forward to 2024, a lot of that has informed what legislation looks like right now. But so that's the context for Communities Together for Health Equity. How we do our work is based on the model of collective action for collective impact, right? So leveraging community voices at various levels and using that as a strategy to be able to shift power dynamics and to ensure that the systems and policies are being responsive to community needs. And so CTHE is known for convening communities, community members, community residents, community-based organizations. And some of these images are a reflection of some of those convenings and some of the planning that happens during those sessions. But very practically, our approach is centered around community-based participatory research. And so our model of how we are able to inform policies and practices is making sure that we're connected to the communities on the ground. And the way that we've done that over the years is listening to the community. So we've held key informant guides, we've held listening sessions with communities, and really creating spaces for communities to tell us what's going on the ground. We take that information, we partner with other community-based organizations, and we develop, we host collective strategic planning sessions. Oftentimes, larger institutions have opportunities, time, capacity, and resources for think tanking, for strategic planning, but oftentimes nonprofits and CBOs don't have that opportunity because of all the work that they're immersed in. And so we are very intentional about creating a space for strategic planning. And then, of course, anytime you're collecting data, information from the community, we're always creating space to report back. That's how we nurture and build trust with the community, is making sure that we come back to say, this is what we heard from you. What are your recommendations on how do we move forward? So making sure that community is involved in every stage of the process is integral to the work that we do. And as a result, they're involved in the co-design the development and implementation and evaluation of all of our interventions. And I'll talk about that a little bit later. And then, of course, making sure that all of these things are translating into action through engaging different stakeholders and informing policies and practices. So how does this translate into action? That model of listening to community voices translated into us hosting community listening sessions. We started with small community listening sessions with 91 community members and leaders. There were 7 sessions. This was during the pandemic, and so all of them were virtual. Because we wanted to have diverse perspectives at the table, we also needed to make sure that those sessions were facilitated in different languages. And so we had them in English, Mandarin, and Spanish. We did them in all 5 boroughs. And of course, we made sure that we honored community members' time by providing them with gift cards. All of these listening sessions were recorded and they were translated and transcribed. And that informed a more robust citywide community needs assessment. So we leveraged community leaders to give us a pulse of what was going on in the community, and then use that information and those leaders to then inform our citywide community needs assessment process. And we know that hospital systems are required to do this every 3 years. We also know that this is what informs how resources are going to be used. And we wanted to make sure that the community was involved in that process. So that needs assessment translated into over 1,000 participants, 537 specifically responded to our community-based participatory research process of engaging in surveys. We had 18 different workshops, virtual and in person. They were in 6 different languages across all 5 boroughs. And we did it in partnership with local community-based organizations. So we know that the Institute has relationships in Brooklyn, but that we wanted to replicate that same model of touching base and leveraging the trusted relationships with existing community-based organizations in different neighborhoods. And so those logos at the bottom represent the wide array of CBOs that we partnered with to be able to hold these community listening sessions. And all of these CBOs were involved in the development of the curriculum, involved in the survey development, involved in the facilitation of the workshops, involved in every step of the process. And that's how we ensured that there was buy-in. So again, this is just a representation of who was in those spaces. So very diverse folks, hugely represented by minorities. So we were able to capture a group of folks who are traditionally not involved in needs assessments at this level. This included documented, undocumented immigrants. It included a huge Asian, Black and African American and Hispanic population, folks who are not English speaking, and then a wide array of ages, insurance status, and languages spoken. And so that translated into two different forms of data collection. I won't go into depth of both, but the qualitative was making sure that we captured people's voices. And so the qualitative aspect led us to very specific themes that came out of what were people saying were challenges that they were experiencing interacting with the healthcare system, interacting with providers. A lot of it was centered around cultural humility, fragmented care, dignified and respectful care lacking, and then of course, just dealing with the social and economic conditions and it just being a challenge and a barrier to receiving healthcare. And on the quantitative side, I'm just going to highlight one piece. On the needs assessment, we had asked those over 1,000 people if they had access to their basic needs, right? That's food, that's housing, that's transportation. And 73% of that population said that they were unable to meet one or more of their family needs as a result of the pandemic. The highest needs, of course, being employment, food, and mental health, followed by housing and access to healthcare. And 51% explicitly said that they wanted someone to contact them. So this is where the care coordination piece comes into play. 51% wanted someone to call and contact them. So the use of community health workers, community-based organizations, and really getting people connected to care was urgently needed. And so I think it's important to note how some of those, how community voices, how community-based organizations informed some of the development of these interventions. Now, again, these are not solutions, but they're tools that move us in the direction that is needed. And so what we recognized is that there was a huge need for care coordination and that access to health insurance, access to community-based organizations, access in general was a huge barrier. And so we developed a tool for CBOs to be able to get people connected to care that could also be accessible by the community. So we have a citywide resource guide that is both done in a PDF format and also web-based. We had conversations with community health workers in community settings, patient navigators, and we had asked them how they get people connected to care, like what tools they use. And a lot of them had said Google. And that's a huge database. They had also said that they obviously leveraged their trusted relationships. And so what we did is we worked with those 70 community-based organizations, and we tapped into their trusted, vetted resources and compiled them and translated into a digital format. We also, of course, leveraged Unite Us to facilitate care coordination. But instead of working on an individual CBO base, we also thought about how this could happen on a larger CBO network process. And if you guys are familiar with what's going on right now with New York State, in 2014, our initial advocacy efforts to have a network of CBOs engaged in the healthcare transformation process 10 years later is now called the social care networks, where they have networks of community-based organizations who are providing care coordination. And so this is just a very high level example of how community voices are informed or playing an active role in identifying issues, informing the interventions, informing the tools that are developed, but also on a larger scale, policies and practices. And that's it for now.
Thank you so much to our presenters for sharing all of their experience and their wealth of expertise with us. And so now we'll open it up to questions that anybody might have or comments. I see that Devin had put in the chat if you had any questions you wanted to jot down to share with us. I'm happy to take those and help them get answered or have a conversation about them. One thing I was thinking about during both of the presentations was, how do we access all these wonderful tools to be able to use, and are they shareable?
Yes, the CTHE related SDOH mapping tool is on our website. I'll drop the link in the chat box. But the perk of that, we know that Unite Us exists, and that's a great resource, but that's only accessible for community-based organizations or organizations in general who have access to that platform. And so the one that I'll drop in the chat box can be accessed by anyone at any time.
Oh, wonderful. Thank you for sharing that.
Great. Yeah, ours is available on our website as well. So let me, Harlem Strong. In our trainings, you know, if an organization works in Harlem, supports folks in Harlem, they're also welcome to join our coalition and access resources through the coalition and trainings through the coalition for free as well.
Oh, that's fantastic. Thank you for sharing that resource.
Yeah.
Thank you. I was also wondering the idea about what were the most challenging, and you can both speak to this at some point, but the challenges in creating the tools and vetting that, what was that process like?
I think it's first a long process. It depends on which tool you're talking about, because we created a lot of different resources. For us, for the training side of things, it was probably about a 6-month process. You know, we worked off of things that we have done in the past and based on the literature and based on best practices in the field, then, reviewing it with community partners to get feedback on it. And then, implementing it. And every round of implementation we ask for feedback. And so it's iterative. Each time we do it, we incorporate the feedback from the previous cohort. So that's part of our process. And in some ways, this iterative, process applies to almost everything we do.
Oh, fantastic. Thank you for sharing that. I know a lot of the work we do for the Institute for Health Equity Research and with our partners is very similar in fashion, but it's always interesting to understand what the process is like for others who are going through this tool building and resource sharing.
And I guess I'll share from my perspective. We worked with a group of 10 community-based organizations representing 2 in each borough, and they were involved in all stages of the process. And so naturally, the conversation about what is needed, how is it needed, like how do we don't have the capacity to address 50%, 500 people of the 1,000 that were assessed. 50% essentially had said that they wanted to be contacted. And so we thought that's 500 people that the 10 CBOs, we do not have the capacity to do. And so how do we respond? How do we make sure that we're taking care of people's needs and continuing to nurture that trust? And so we just started the conversation by asking CBOs, well, how would you get these people connected to care? And they had all said, I would get them connected to my partner at this organization or our partner at this organization. These are trusted and vetted. And so we use that as a as a foundation to then have them share all of the resources that they say these are trusted, vetted, and then we had to call, we had to identify point of contacts. So it was an iterative process again, and also one that took a lot of time because you have multiple voices at the table, and making sure that when you're saying that resources are vetted, the last thing that you want to do is have a resource listed and then they don't have a good experience, or the resource is not available. And so making sure that included community voices and also was vetted was challenging, but I think worth the process.
Yeah.
Oh, thank you for that. Absolutely. I can understand that because everything's a process, and sometimes really embedding that into the research workflow or the programmatic workflow, that it's going to take time to build these relationships, always taking us back to trust.
Yeah, and I guess I would add also, I know that in academic institutions and hospital systems, there's a lot of bureaucracy and a lot of challenges with time, and oftentimes you don't have the time for community voices to equitably be integrated into the work, right? Sometimes it's just too much time. I would just say that if you want your interventions or your research to really respond to what's going on, that you have to advocate for creating that time for community members to be involved. And one of the things that we talk about is that there's a difference between community engaged research and community-based participatory research. And sometimes those two are intertwined.
Very good point. We have these conversations internally quite often, actually. Thank you so much for sharing.
You're welcome.
We have time for a couple of more questions.
Can I thank you both so much for sharing your work and how you've elevated community voices in every aspect of your work. I was wondering if you could take a step back and just from a personal standpoint, reflect for a moment on how this community engagement and the participatory research that you do, how did it affect you personally in a way that sort of adjusted how you think about research or ideas for sort of ongoing work? Like, I mean, I think you both highlighted ways that community voice shaped, the directions of your work. But I was wondering if in any fundamental way your thinking about research shifted in this process.
Yeah, for me, absolutely. I mean, I think, I come from a background where the gold standard is RCTs, randomized controlled trials, and just, it's about making sure you adhere to whatever your protocols are, and that was ultra important, and that was very, like the end game is to make sure you're doing a good job in implementing your RCT. And I think, now that I've been, engaged in community participatory research and, just research that's happening in the community, it's, I realize there's just a lot more value in actually understanding what is useful for those organizations, and what's useful for an organization or for community is not always what's useful for the field. They're not one and the same. Knowledge building and science building is a different, may or may not be in alignment with what is needed in the field. And so it's difficult because the kind of funding we go after is about knowledge building and science building. And so if you do what's needed, sometimes you have to reframe it so that it's like, how is it addressing a gap, in the field? Sometimes it's not a gap. It's like, we know what is the problem. We just need to do it, so, which actually has moved me more into the implementation science space in terms of understanding the process to make it happen in the community, versus studying the interventions.
Crispin, I have a question. I'm wondering, Dr. No, you just mentioned implementation science, and I'm wondering if you had a particular approach or model for engaging the organizations that you could share with us?
For me, it's not really a specific model. I mean, it's just, I think CBPR comes in many forms, right? And it depends on the resource, depends on the kind of partnerships and how much people want to be involved and in, what capacities. And so just figuring out what the wins are, what works. So I take a more pragmatic approach in that sense, in terms of just figuring out what works and what is available. Much of the stuff that we do is, it's sort of like, a little bit more flexible, so people come on the bus when they're available and able to, and it's like on and off the bus sort of partnership, so that way they don't feel the need to decline if they can't make certain meetings, they can always join and they hear about it, and so it's an open door.
I had one question for Victoria. For some of the work that's going on in Harlem, I know that we're, as a health system, trying to focus more on Harlem. We opened up a new ambulatory practice this past year that kind of focuses on a lot of mental health resources. So
Oh,
as a
great.
hospital, how can we, better partner with you on some of the work?
Oh, let's just let's have a side conversation. We can talk more about that. I would love that. For anybody that's doing work in Harlem, we would happily, co-table with you or collaborate in whatever ways make sense. Sharing resources, helping to support referrals. Much of this is about just like knowing who's out there, right?
Yeah. Great. I'll reach out to you after this.
Okay, great. Thank you.
To close out, Faven, do you want to answer Neeta's question briefly about how the research has changed you?
I think it's just grounding. I came into public health because I come from an immigrant household and recognize that the social environment and social factors are more important or just as important as the healthcare ones. And so I think being in the middle of a CBO and also working within a hospital setting, sometimes you're toggling between bureaucracy and you're toggling between like what actually matters on the ground. And so I think working with community has just grounded me, and just making sure that we're being creative and we're leveraging the technical trainings that we participate in, our educational training, but we're making sure that it makes sense to the community, right? CBPR, research, all the fancy things are irrelevant if we're not doing something that actually impacts the community that we serve. So just staying grounded in that perspective has been impactful.
It sounds like you two have something in common in how the work has affected you. At the end of the day, you want to do the things that the community really needs. And it kind of came back to that, which is, and us not deciding what that is, right? So really hearing it and then not doing research for research's sake, but really trying to fill the needs. And I think both of you voiced that so eloquently. Thank you so much for inspiring all of us to do this important work.
Thanks for the space to talk about it. Appreciate it.
Thank you so much. All right. I think we're at time, so just to be respectful of everyone's time, but thank you so much. This was such a great session. Please fill out our feedback form and I'll join our next session, which is on September 25th.
Thanks, everyone.